Well, hi everyone. My name is Dr. Michael Hockman. I'm a primary care doctor internist at Ultimate Health Services, which is a community health center in Southern California. I've been involved in the primary care leadership program here at Ultimate for the last 3 years. And as I always tell my students who rotate through here, it is absolutely our favorite time of year. You guys bring great ideas and energy and really help us out a lot with those projects you do. So very happy to have you guys coming back, and especially a hi to the Ultimate people who are going to be joining our team this year. So I've been tasked today with telling you a little bit about patient-centered medical home and how this has been something that we've focused on at community health centers in preparation for your time here this summer. So I'm going to talk about a few things. First, I'm going to talk a little bit about this concept of the triple aim, which is a term you'll probably hear a fair amount this summer. Then I'm going to talk a little bit about how this relates to patient-centered medical home. Then I'm going to talk about our role at community health centers in embracing the patient-centered medical home model, and then hopefully, at the risk of being the bearer of bad news, I'm going to tell you about a couple assignments that you're going to be doing this summer. So first, the triple aim. This was a concept that was developed by Don Berwick, who was the founder of an organization called Institute for Healthcare Improvement, which was really one of the first premier quality improvement organizations, and Dr. Berwick subsequently went on to become the administrator for the Centers for Medicare and Medicaid, so a very important person in healthcare. And he wrote a paper that you guys are going to read as one of your assignments in 2008 that introduced this concept of the triple aim. So the three arms of the triple aim are one, what's called population health, secondly, the experience of care, and then third, the per capita cost of care. So let me unpack each of those for you. So probably the most straightforward of those is the cost of care. As we all know, there's been a steady but very detectable rise in the cost of health care. It's now represents about 18% of our gross domestic product is spending on health care. And there's a growing recognition that not all of this spending is adding value. In other words, that there's some waste in our system. And so we have an imperative to try to slow this rise, not by reducing quality of care to patients, but to getting rid of some of that waste. And then hopefully we can use some of these resources for other areas in the economy that are also important, such as education. So the second arm of the triple aim is the experience of care. And the experience of care really refers to the quality of care that patients get when they come into our healthcare system, and also the service that we deliver. So in terms of quality, that's really a question of how good a job do we do of getting those mammograms done, those colon cancer screenings, or how good are we at controlling diabetes and doing all those process things that we're supposed to do related to quality of care. The service is when a patient calls and needs an appointment at 9 o'clock at night, are we able to accommodate them? Are we able to give them good telephone service? When they come in, does the front office staff listen to them and engage with them, and so forth? So that's the experience of care. And then the third pillar is population health, and that's maybe the one that's a little bit more abstract for some people, but when you think about it, it really is fairly straightforward. So population health is just how are we doing at promoting health within our population with respect to hard outcomes, such as life expectancy. Are patients in this population living as long as they should, given modern medical technologies? Infant mortality, quality of life. So not just are patients living as long as they can, but is healthcare and chronic disease impairing the quality of that life? Also the burden of chronic diseases in the population, as well as risk factors. So this goes a little bit beyond the traditional medical model, where we're actually trying to think how can what we do prevent disease, addressing those risk factors like being overweight, smoking, and so forth. So this might involve some partnerships with community organizations. So the triple aim is trying to simultaneously focus on and address those three things: the cost of care, the experience and quality of care that we deliver, and simultaneously making sure that these efforts lead to population health. So the question is, how does this relate to patient-centered medical home? So we really think at Ultimate and many places that patient-centered medical home is the tool that we use to achieve the triple aim. We really believe that primary care is foundational to the health of a population, and that by building and enhancing primary care through this vision of patient-centered medical home that will be able to achieve that triple aim. And so our Chief Medical Officer here at Ultimed, Martin Sirota, always says this, that PCMH is our tool for achieving that triple aim. So the primary care movement's been going on for decades, that people have recognized the importance of primary care. Famous work by Barbara Starfield at Johns Hopkins, which has shown that health systems that are based on a strong primary care infrastructure are more efficient and deliver better value than systems that don't have as a strong primary care infrastructure. But this concept of patient-centered medical home really began in 2007 when several professional organizations, the American College of Physicians, the American Academy of Pediatrics, American Academy of Family Practice came together and issued these principles of the patient-centered medical home model. And here's what those principles are. So the first 5 I have in black because I don't think they're really much of a departure from that traditional view of primary care, but the last 2 are a little bit different, so I've highlighted those. The first is personal provider. The concept that every patient should be assigned to a provider, a physician, nurse practitioner, a physician assistant who's responsible for all their medical and health care needs. The second is that it's a whole person orientation, that we really need to go beyond just the medical issues, but how those medical issues intersect with the social and economic conditions that a patient is facing. The third is that care should be coordinated. It shouldn't begin and end at the 4 walls of a primary care office, but that we should coordinate care with hospitals and specialists that our patients see in the community. Enhanced access to care, that we shouldn't sort of be open just banker's hours 9 to 5, but that patients sometimes have needs at night and on weekends, and that they should be able to get at least phone access and ideally, when necessary, in-person primary care visits at these after-hour times. An emphasis on quality and safety is a big part of the patient-centered medical home focus. And then the last 2, again, I'm going to spend a little bit of time, a shift to more of a team-based approach and new payment models. So hopefully we have a couple USC fans out there, although for those of you not in the LA area, you probably don't care very much about the USC-UCLA rivalry, but we take it very seriously. So this is a shift from that traditional view that everything needs to fall on the primary care doctor's shoulders. We've learned over the years that when that happens, primary care doctors become overwhelmed, and so do primary care providers, nurse practitioners, physician assistants. So we've realized the value of moving to more of a team-based approach where you work with social workers and therapists and health educators and case managers, and collectively that team is able to take better care of a patient more efficiently than any one individual primary care provider can. And the second is very simply that investing in this patient-centered medical home model, for example, getting that nurse advice line on nights and weekends and keeping the clinic open on Saturdays and hiring those case managers and so forth, that requires an investment of resources. These are just can't be extra add-ons that we do without any recognition of the value it provides and appropriate reimbursement to sustain these changes. So this might come, for example, in a monthly fee for clinics that are achieving a certain number of these criteria, or an extra payment or something along those lines, but there needs to be some extra payment for these extra services that are being provided. So there are 2 main agencies, the National Committee on Quality Assurance and the Joint Commission, which certify clinics as patient-centered medical homes. Here at Ultimed, we are certified by both of these organizations. And I will say, I think these certification criteria provide a very important and nice framework for sort of moving your organization or your primary care clinic towards a patient-centered medical home model vision. But at the end of the day, these are just a list of check boxes, and it is possible to check the boxes without substantively making important changes to improve the quality of care. So I think that's a very important thing to recognize, that just because you're certified doesn't mean you're necessarily delivering on the key outcomes. So here at Ultimed, we believe that the patient is at the center of that patient-centered medical home model of care. We have teamlets of a provider, a physician, PA, or nurse practitioner supported by a couple medical assistants, and together they work with the care coordination team, the team-based approach to provide the care that the patient needs. And here's just some of the key members that we have on our patient-centered medical home team. We have a RN case manager who focuses on the high-risk patients with frequent ER and hospital visits. We have promotores or health coaches who do a lot of the disease education. We have referral specialists who coordinate care with the hospitals and specialists that our patients visit. We have therapists who actually on-site do behavioral health and mental health counseling. It's been a tremendous addition to the team that we don't have to send patients out, but we have the therapists right in the clinics with us in primary care. Clinical pharmacists, we've had clinical pharmacists who do chronic disease management right on site for us. Medical assistants, we've been thinking innovatively about ways that medical assistants can go beyond the traditional role of just checking patients in, but that understanding orders, they can do make sure we're hitting our quality measures, that they can do some health coaching for a patient with newly diagnosed diabetes or other chronic conditions. They can even do scribing to help record and document some of the information the patient is telling us, offloading some of that work that a provider doesn't necessarily need to do it. And then, of course, the community link. So here at Ultimate, we partner with the YMCA on their diabetes prevention program, which is a lifestyle program. We have relationships with parks and other organizations that promote healthy lifestyles and many other organizations along those lines. So I just wanted to have one slide in here to emphasize that patient-centered medical home refers to the primary care clinic. We believe very much that the primary care team is at the heart or the center of the healthcare team. But those other players, the hospitals, the specialists, are also critical, and we're all part of a medical neighborhood that is jointly and collectively accountable for the care of the patient. And that's, you may have heard the term accountable care organization or accountable care network. So this is the entire medical neighborhood, including the specialists, the hospitals, as well as us in primary care. And again, we think that the medical home is the heart of the accountable care organization, the center of it. So community health centers have really embraced this concept of patient-centered medical home and the patient-centered medical home model. I was recently at the National Association of Community Health Centers national meeting, and more than half of the organizations were formally already in the process of becoming certified as patient-centered medical homes, and many of the others were thinking about doing it. So it's something we've really believed in, but it's been a challenge. And some of the challenges that we've faced is, for example, shifting to this team-based approach is a little bit of a cultural shift. I think many doctors and other professionals have sort of grown up with this model that everything, the whole responsibility and accountability should fall on the primary care doctor's shoulders. So it's a little bit of a change, delegating some of these responsibilities, for example, lab follow-ups and case management, to other team members. Secondly, the business case. Like I said before, there needs to be a recognition that doing these extra things that we do in primary care, the nurse advice line, the lab follow-ups, the team-based approach, that this does require an investment of resources, and these extra payments haven't come along as we had hoped. So many of us are needing to think creatively about how to make the business case for making these changes. Partnerships with hospitals and specialists are very important. We're not an integrated organization. We actually have to reach out and put effort in building those relationships with hospitals and specialists. And similarly, we need to put some extra effort into forming those relationships with community organizations so that we're all on the same page and in alignment to help the patient get the best care possible. Okay, so that was my overview of patient-centered medical home and the triple aim. And now to that assignment that I mentioned to you. So there are three things that I'm supposed to tell you about. The first is there are 3 articles that you'll be expected to read. Then there's a webinar, and then there's a leadership interview. So first, the 3 articles. The first is the Triple Aim article that was written by Don Berwick that I alluded to before. The second is a brief on patient-centered medical home from the Department of Health and Human Services. And the third is an excellent article by Dr. Barbara Brantz, who is on the PCLP National Advisory Committee, and she has talked about the important role that you as trainees have in helping us think through the patient-centered medical home model, because as I said before, you all have great fresh ideas, and we are always looking to refine and enhance this model. So that's a great article, and I think you'll enjoy reading. You will have a webinar So there'll be more details sent out about that, as well as the references, and please try to have those articles read in preparation for this webinar so it can be a good discussion. After you've had that webinar, you'll have the opportunity to interview some of the leaders at your healthcare organization and discuss healthcare reform and their particular approach to patient-centered medical home. So again, thank you for taking the time. We couldn't be more excited to have you all coming this summer. If you have any questions about this or any other related issues, feel free to reach out to me, and best of luck this summer. Thank you.